With so much excitement around immunotherapy in the setting of lung cancer and many other cancers, it's understandable that many patients and potentially physicians would be interested in the question of whether immunotherapy can even extend to a subgroup of patients in whom we have generally expected rather disappointing results with immunotherapy. I'm speaking specifically about the group of patients with a driver mutation such as EGFR or ALK, and the early work primarily in the setting of single-agent immune checkpoint inhibitors compared to docetaxel in second-line or later advanced non-small cell, where we've seen that the patients with an EGFR mutation, and in some studies potentially other groups like never smokers, maybe those with ALK rearrangements, have generally fared less well than just about any other group. And it hasn't been a lot of data, but it's been pretty consistent, suggesting that these patients have gotten the least benefit from immunotherapy. Nevertheless, we've seen immunotherapy move into the first-line setting, potentially as a single agent or in combination with chemotherapy for more and more patients. But most of these first-line studies have systematically excluded patients with an EGFR mutation or an ALK rearrangement for a couple of reasons. One, we have oral targeted therapies for these patients that are typically very well tolerated and extremely effective, even with response rates that eclipse what we've seen with immunotherapy. And second, as I mentioned, the early work has suggested that these patients may be the ones who get the least benefit. But it seems reasonable to test this question just to clarify whether immunotherapy might be very effective for some of these patients in the first-line setting. And here we have an early trial that addresses this, that actually was stopped early because it provided a clear answer. Doctors Lisberg and colleagues from UCLA, the senior investigator in this group being Dr. Eddie Guerin at UCLA, did a study that was planning to enroll 25 patients with an EGFR mutation who also have high PD-L1 tumor expression of 50% or greater. And this is the subgroup of patients who, at least if they didn't have a driver mutation, we would routinely recommend single-agent pembrolizumab as an FDA-approved option based on the KEYNOTE-24 trial that showed superiority of pembrolizumab over doublet chemo, this trial excluding patients with an EGFR mutation or ALK rearrangement. So this study by Lisberg and colleagues that was just published in the Journal of Thoracic Oncology, as well as presented at ASCO 2018, reported on their experience in which they enrolled 11 patients with an EGFR mutation and high tumor PD-L1 expression and gave first-line pembrolizumab. As you can see from the waterfall plot, there was really disappointing lack of response, and in fact there was only one patient who did have an objective response on the far right in the yellow bar. This patient actually had EGFR wild type on subsequent confirmation. So here we see the exception proving the rule, and none of the 10 patients who had an actual EGFR mutation had an objective response to pembrolizumab. Very disappointing and unusual compared to what we'd expect for patients getting pembrolizumab, at least with high PD-L1. So suggesting this is just a different scenario. In addition, the investigators saw disappointing results in terms of the duration on treatment, and even saw 2 patients have an early death in the first 6 months, which is quite unusual for patients with an EGFR mutation, where we routinely expect to see our patients living for several years very well on first-line EGFR inhibitors and subsequent treatments. And even when patients switched promptly from pembrolizumab to an EGFR inhibitor, they often had less favorable results. In fact, one of the 2 early deaths was in a patient who developed pneumonitis while on an EGFR inhibitor. So after he had previously received pembrolizumab and stopped it, developing fatal pneumonitis on erlotinib. So really very disappointing. And if we look at the so-called swimmer's plot with the horizontal lines for the duration on treatment, the only one that is an ongoing response and ongoing treatment on pembrolizumab is at the bottom, and this is that patient who actually doesn't have an EGFR mutation. So what can we say about this? This is not a large study. It was stopped early with just 11 patients, but I think that's all we need to clearly illustrate that this is not the treatment approach we want to pursue. And I would say that with all of the enthusiasm around immunotherapy, and particularly giving, say, first-line pembrolizumab or potentially combinations to patients with high PD-L1, one might be tempted to try this more widely in patients with an EGFR mutation or other driver mutation. What this work, I believe, clearly shows us is that this is not the approach to pursue. It was unfortunate that these patients did poorly, but it is a credit to the investigators that they stopped it, and we have the opportunity to learn from this rather than have this pursued more broadly. We need to get the word out that patients with a driver mutation should not receive first-line immunotherapy, even if they have high PD-L1.